From the University of California, Irvine, this is UCI MIND's Spotlight on Care, the podcast where we share stories, experiences, tips, and advice on caring for loved ones affected by Alzheimer's and other dementias. Well, hello, everyone. Welcome to Spotlight on Care. We're very excited to have Dr. Michelle McDonell with us today. And she is a clinical neuropsychologist, and she currently works at UCI MIND. Michelle has a PhD in clinical psychology, postdoctorate from Loma Linda Veterans Administration, and she has an interesting experience working with lots of veterans, which has been really a big part of her life and taught her a lot. She's an expert in cognitive evaluations and cognitive psych evaluations, so we're very excited to have her talk about that whole area today. But before we get started, Virginia, you want to share any of your experiences with cognitive or evaluations or testing?
You know, I didn't know what to do when my mom was showing signs of dementia. I had no idea what to do. So I just picked a doctor to go see with her, and the whole experience was just horrible, basically horrible. He gave us a pill pack, a 7-day pill pack for Aricept, and an order for an MRI. And he wasn't encouraging. I didn't have any confidence in him at all. I never found someone to evaluate us. I never did.
Yeah, my experience had a somewhat similar background. I share this with Dr. McDonell already, but we went to Patty's internist, and I said, you know, she's really having some memory issues at work and at home. And he goes, oh, well, that's not uncommon, yada, yada. And then he goes, we'll give her a little test. The next thing I know, he pulls out this sheet of paper with 5 questions on it and pronounces her fine. And I'm like, no. So that really didn't work. And eventually we found our way up to UCLA and went through a full battery of cognitive testing. And so I'm a big proponent of that. And I think that that's why I'm so excited, or we're both so excited to have you here, Dr. McDonell.
Well, thank you so much for having me. I'm excited to be here.
So what are some of the valuable lessons that caregivers and patients should know about why cognitive evaluations are very valuable to do?
Well, I think it's important to consider that cognitive evaluations really allow you as a provider and a caregiver to have the brain be taken on a test drive, right? And I've already heard a couple things from both of you. You mentioned that your wife, they did a brief cognitive screener and found out she was fine, right? But you were noticing things at home, right? And you were saying, I didn't get good care and I wish that I had more answers. So a cognitive evaluation is the place to get more answers. So we don't only just do tests to assess somebody's attention, learning, memory, executive functioning, all of these different cognitive domains. We spend time with the family and the caregivers and the patient and do a thorough clinical interview. So we ask all questions about their current signs and symptoms. We ask about their experience growing up. How were they in school? What's their health history? Have they had strokes before? All of these questions. And we kind of put it all together to create one full picture. So it's not uncommon for patients who go through a cognitive evaluation to spend 5, 6, 7 hours with us in total. And we also go through their entire medical record when available and look for these other things, these other possible things that could be impacting their cognition. Maybe not the root cause, but is it making it worse? Then we provide recommendations, a diagnostic differential, right? Is it Alzheimer's disease, vascular dementia, dementia with Lewy bodies, and then recommendations specific to that person. And not only are these recommendations things like maybe consider starting Aricept or go back to neurology and consider some other treatment options, but can also be focused on these individuals' current strengths, right? So if they still have valuable visual spatial memory and their learning and memory and verbal components is impaired, let's lean on this strength. How do we build this into their day-to-day life so that they can still get the best out of their day?
Okay, you're giving the whole answer in one fell swoop, which is good. There was lots of great information.
Yes.
But let's go back to value. Isn't one of the values of doing this testing kind of being able to rule out things?
Yes.
So maybe you would talk a little bit about that.
Many of the values is absolutely ruling things out. There are hundreds of things that can impact cognition. We consider not only the neurodegenerative disorders, Alzheimer's disease, dementia with Lewy body, frontotemporal dementia, but we also consider things like depression and PTSD, anxiety, kidney failure, liver failure, substance use issues, sleep apnea, insomnia. And a lot of what we're trying to do is figure out, is the person presenting with depression and it's appearing to mimic dementia, or is it something else? So it's not uncommon in research and in clinical work. Depression is called pseudodementia. And it's not uncommon for a patient to arrive at a primary care provider's office or a neurologist's office and either get misdiagnosed with depression or misdiagnosed with dementia because the symptoms overlap each other so similarly. But when they do a neuropsych evaluation, the pattern on testing is different. And so it helps us to kind of parse this apart and be like, okay, the depression is impacting them so much that they are struggling with their day-to-day tasks, their ADLs, IADLs, versus no, they are exhibiting signs of depression as a component of their neurodegenerative disorder. So it really helps us piece these things apart.
That's common, right?
Yeah.
For people to get depressed when they realize their brain is not working the way it should?
Well, it depends. So there's like naturally sadness that can happen. But what can happen is individuals disengage from the activities they used to enjoy because they're increasingly complicated or difficult. They're declining and they can't really engage in the way that they used to. So they present with signs of apathy or disengagement because they're like, oh, no, I'm just not in the mood. Oh, no, I don't want to do it. When they don't necessarily have the insight that they don't want to do it because they realize they cannot do it. So there can be some separation in the quality of those depressive symptoms, with apathy and amotivation being maybe a little bit more aligned with the neurodegenerative disorder, whereas feeling blue, feeling down, feeling sad, and worthlessness might be a little bit more attributed to like a core depressive symptom.
Okay, you've talked a little bit about evaluations and why it's important to do them earlier rather than later. Could you talk a little bit about that? And again, thinking about it from the caregiver's perspective.
Absolutely. So it's better to do it earlier rather than later when one of the primary concerns is what's happening here. So when it happens earlier, we're able to identify patterns on testing, and these patterns can help point us towards what is causing the cognitive inefficiencies. When people start to decline in their disease process, a lot of dementias start to look the same because as the disease progresses, it starts to impact various other cognitive areas. So while memory may have been first, now it's affecting language and maybe executive functioning and processing speed. And so it becomes a little bit muddier, and being able to determine the contributing factors becomes more difficult. So when you think as a caregiver, what resources should I use? What treatment options are there available? The later in the disease process, the harder it gets to kind of get the benefit out of the testing. Whereas if it's earlier, there are more recommendations, more pros and cons, more things that we can help guide caregivers to so that they can optimize their loved one's care.
You've also mentioned that you don't really recommend testing as the disease progresses. Could you talk briefly about why?
Yeah. So testing is exceptionally taxing. It's probably one of the most exhausting things that a patient can do. Like I mentioned, they're here for hours with us. And as the disease progresses, they present with what I call floor effects. So no matter how they perform on testing, their scores are going to look impaired, and then they start to look impaired across the board. So I've put them through a very arduous, straining, exhausting event to get impaired scores across the board, right? So rather than put them through a lot of those things, I'd rather maybe have a neurologist, maybe do a cognitive screener to identify if there's been a decline. But a lot of the information about decline can be assessed with a clinical interview with the primary care provider. Well, what are some things that have changed now? Testing is just so hard on patients that especially if the value of it, the outcome is going to be impaired across the board, I don't want to put them through that.
Yeah, I remember we did testing for 5 years, and the last 2 times, Patty was exhausted, just exhausted, got home and fell asleep immediately from the experience. Is there something, let's talk to the caregiver again about maybe criteria that they should look for that would suggest that testing would maybe be, or an evaluation would maybe be worthwhile?
Yeah, I think the thing that people struggle with the most is they'll say, I noticed something's not right. My loved one is maybe forgetting more, but not everybody sees it, but I see it. I live with them, I see it. And maybe they'll go to the doctor and, they'll give them that cognitive screener and they're like, no, they're fine. I don't know. This is just normal. This is normal. And you're like, no, this isn't normal. So part of it is having to be an advocate for your loved one and identifying that it's not normal. I always acknowledge that there are normal changes in aging, right? So you don't compare an 83-year-old to a 20-year-old, whether it's brain or body. They function differently. There are natural parts of aging. But when it exceeds what's natural is where we have to be concerned. And in the beginning, it's really muddy to figure that out. What is natural, what is not? But I look for consistency. So if they're maybe forgetting things daily and they're forgetting these conversations and you're noticing that you're repeating this often, and it's regardless of the situation, right? Regardless of how interested they are. If they are a painter and they're maybe struggling a little bit more with painting and it's happening daily and they're forgetting if they started it or they're forgetting where they're at, that's something to consider. So I always encourage having a journal and just kind of tracking these things. Is it happening consistently? Is this something that's happening more frequently than not? There are instances when people will have depression and they'll have a really good mental health day and they'll kind of get out of this cloud, out of the slump, and now they're doing all of these things without difficulty, right? And they're not having the same problems. But it's when it's happening across the board and when we're seeing it more frequently and you're noticing that, I would advocate for that and say, I understand that you maybe don't, as a physician, you maybe don't acknowledge that they're having these difficulties, but I've noticed it in the morning, at night. I notice it when the grandkids talk to them. I notice it when their brother calls. They forget that their brother calls, and this is happening daily.
Yeah, you mentioned this journal idea when we chatted before. Could you just touch on that briefly?
Yeah.
What you think the journal is about, and why would I start it? I mean, it's like, I don't really worry about this, and then all of a sudden I need to. I mean, is it like just a handwritten notes, or is it a book? What do you recommend about the journal?
I recommend whatever is easy and accessible to you, whether it's a notepad on your iPhone, whether it's a email, like a unsaved or a draft of an email in your email, piece of paper, a notebook, whatever is accessible to you. And it's just going to be something where you kind of identify those difficulties. And you'll say, oh, they forgot to pay the bills again. Right? And I noticed that this thing happened again, right? Or they really struggled to find the words today multiple times to the point where they just stopped talking. They didn't want to be involved in the conversation anymore, right? So kind of taking those notes down. And again, it feels really nitpicky at first. And it feels like, oh, I'm judging their every movement, right? But it's helpful to identify when it's happening, not only for you to be like, am I seeing something that isn't there, or helpful for a provider, right? Because if you can identify when it's happening, because if it's not happening consistently, like if they started a new sleep medication and they're groggy in the morning, and that's when you notice that this is happening, but when they stop their sleep medication for 3 days, they're fine. Okay, maybe it's not cognitive. Maybe we need to stop this medication. So it can be helpful too to kind of say like, oh, these other factors are affecting cognition.
It would seem to me that by keeping a journal, you could take that with you to the doctor's office.
Absolutely.
Because I had doctors saying, she's fine. And in the meantime, on the way there, from her house to the doctor, she would look over at me and say, I've never been on this road before.
Right.
I'm like, yes, you have.
We've been here 30 times.
Oh, it's a lot more than 30.
Right? Yeah.
Right, or repeating things over and over again, even if it seems insignificant, to write it down and be able to say to the doctor, okay, this is what's happening. Not just an interview with the doctor, because I would walk out and he would say, she's fine.
Absolutely. And it's not uncommon for individuals who are well put together, very social, really intelligent individuals to really fly under the radar for an extended period of time, right? So the doctor's like, they're fine. And you're like, they're not fine. I don't know what to do to prove to you. So having this journal to say, well, they forgot to pay the bills January and February. They forgot to do their medication refill both January and February, documenting that and saying they're forgetting these very tangible things, or I'm having to remind them more often. I know that they appear okay to you, but I'm living it and I'm scared.
So one of the things you're talking about here is not necessarily so much the specific items, although a range of things could be important, but it's the frequency of the fact that they're happening.
Exactly.
Yeah. That's certainly been my experience. You talked about these things called cognitive screeners. So what kind of screeners exist? I mean, 5 hours is a long time for anybody to go through. Yes. What might be something that would be an earlier stage that somebody could encourage their doctor or ask for at their doctor? Hey, I'd like you to do this test.
Yeah, so there are a couple different cognitive screeners. The most common happen to be the MMSE and the MoCA. So it's the mini status and the Montreal.
Could you explain the details of what those things are?
Yep. So they are essentially snapshots into somebody's cognitive functioning. They take anywhere from 5 to 10 minutes, depending on the version. There's also a version called the SLUMS, and it's administered at many VAs, and it mirrors the MoCA. But what they do is they just take a really brief snapshot of maybe a little bit of memory, orientation, right? Date, place, those sorts of things. A little bit of attention, maybe having you write a sentence or visually copy something, maybe draw a clock. But again, this is 5 to 15 minutes if we're really stretching it, right? So again, it's just a snapshot. The benefit of them is that they can be sensitive to mild dementia and even some stages of MCI. Now, if you have somebody who's in the earlier stages of MCI, they're going to come out looking pretty normal. Even some individuals, depending on the diagnosis, look normal at mild dementia. So they have high sensitivity, really low specificity, and it's great to say this is where they're at. They need further testing beyond that to really figure out what's going on.
Okay, thank you. I think that's helpful because not always easy to get 5 hours in a row.
Yeah,
but
and to be fair, a lot of neuropsych testing, it can be up to 8 hours, but typically for a dementia evaluation, it might be an hour and a half, and then add an hour for a clinical interview. So it's not impossible. It is still very taxing. And even our, at UCI MIND, our longitudinal study, these are about 3.5 hour long batteries. Yeah, and they do it annually every single year, and they're tired, and I feel for them. I absolutely do, but I just appreciate, their commitment to the study too.
Sometimes it's difficult to get your loved one to see the value of the testing or the cognitive evaluation. What tips might you give our caregivers that would be helpful in terms of ways they might encourage their loved one to participate in this?
Yeah, I think that is probably one of the harder things to do is to convince a loved one to do the neuropsych testing, because what people don't realize is that, particularly in the state of California, there's a lot on the line. So as a neuropsychologist, I'm not a mandated reporter. However, if at the point in testing this individual does meet criteria for dementia, their primary care provider, neurologist, those are mandated reporters. And so they may be required to call the DMV, notify the DMV that this person does have a dementia diagnosis, and they are at risk of losing their license. And as a neuropsychologist, I let individuals know that that is a risk every time that they engage in testing. I want them to know with full capacity what the pros and cons are of testing. That is a con, and that's a huge one to overcome. And some people don't want to, especially living in this area, right?
So what is the tip to get the person to agree to do it? You've explained what the risk might be, but what's the reason why, as a person, you're looking at me and you're saying, Steve, here are the reasons why we should go and get this test.
Right. So the reason to do it, the biggest one is what's happening, right? So a diagnostic differential, being able to figure out what are the many factors that may be contributing to somebody's cognitive impairment. It's not uncommon for me to say that there are, the contributing factors are multifactorial. Yes, they have a neurodegenerative disorder, and also their depression is exacerbating it. They have sleep apnea, which is exacerbating it. So how do we control these two controllable factors to alleviate the pressure on the dementia, right? So being able to find that out, being able to get an identification of your strengths and weaknesses, right? We want to lean on somebody's strengths. If their attention is still really good, let's lean on those strengths to help compensate for whatever their impairments may be. How do you structure somebody's environment?
Michelle, honey, I'm fine.
Right.
I don't need any of that testing.
Right.
So what you, to me, it's like, something's wrong, but you're afraid to want to find out. And the advantage of coming in and getting it early is, well, maybe it's an imbalance. Maybe it's sleep apnea. Maybe it's some of these other things. And it's not the thing you're most afraid of.
Exactly. Yep. It's all
Thyroid.
those. Absolutely. Thyroid,
B12.
kidney functioning. All of these things can be impacting that. And those are things that we always want to screen even before neuropsych testing, because if those things are clear, or like maybe B12 is out of whack, so to speak, let's get that treated before you do neuropsych testing. I don't want to make you go through that if we can kind of have some recovery with some of those things. The other value for doing this and trying to convince somebody to do neuropsych testing is kind of learning where they're at. Because I think where a lot of people are is that they are afraid. And I think it's acknowledging that there is some fear for this, and acknowledging that not only are they afraid, their loved ones are afraid. And maybe getting some answers can kind of put a name to the creature that they're afraid of. Because sometimes it's, what if it is this? What if it is this? What if it is this? And now you're catastrophizing about all of the 50 different potential options that it could be. And while sometimes the worst case scenario is the answer, at least there is an answer.
Well, we all want a magic pill.
There
isn't one.
I know. Not yet, right?
Not yet.
Well, we're not going to get into it today, but there are some new things now that are available that can help if the disease is identified sooner.
Yeah, and that it helps particularly if the disease is Alzheimer's, right? But there are other neurodegenerative disorders, right? Dementia with Lewy body, I don't really know of any available treatment for that that's at the same level as Alzheimer's disease or frontotemporal dementia. Whatever these are, the treatments vary. So maybe it wouldn't make sense to do Alzheimer's treatment for somebody with like a BV-FTD. That's different. But let's get some answers to help direct what care looks like specific to those disorders.
Okay, what things can caregivers do to help their loved ones maintain cognitive abilities and their memory? So now we've done the testing. We know what's going on. What can we do as caregivers to help our loved one try and maintain their cognition?
Yeah, I think the number one staple I say is I want you to make sure that they stay cognitively, socially, and physically active. That's doing things that are with friends, family, social things. That's doing things that are cognitively taxing, puzzles, whether it's crossword puzzles, jigsaw puzzles, playing bridge, playing a musical instrument, making sure they get their daily walk in, whatever that looks like for exercise. For caregivers, I think this is where the problem is that as people start to decline, the degree with which they want to engage in these activities can also decline. So it can feel really like you start to feel like you're pestering your loved one, being like, please do this, please, let's go for a walk, let's do these things. You used to love to do puzzles. Why aren't you doing puzzles anymore, right? And it's because these tasks are growing increasingly difficult for them. So you, as a caregiver, want to assess maybe where they used to be, and let's still do a similar task, but less challenging. So we don't want them to stop altogether, right? So if they used to do 1,000-piece jigsaw puzzles, let's try 500.
I was just thinking of that example. That's a great analogy.
Yeah.
Or ones with bigger pieces.
Exactly. Yeah, ones with bigger pieces. Those sorts of things, right? If they used to do bridge competitions, maybe let's do bridge with like 2-3 friends and make it fun. Maybe not, don't put money on the line, right? But you still want those degrees of activity and engagement. I think the pressure of there's little insight to know, because it's not uncommon for individuals with dementia to not realize that they're not good at things or not realize that they have a problem. And then they get confronted with this task and they're like, oh, I don't want to do it. I don't like it anymore. I'm fine. No, thank you. Right. And so when that happens, it's not coming from a place of I don't like it. I think it's interpreting that as, okay, this is challenging for them. So how do we modify this so it's still enjoyable and engaging?
Let's go back and touch a little bit more on the social thing. You touched on the activities and the exercise. What about social things?
I encourage social things, whether it is getting coffee with friends, whether it's going to the grandkids' dance recital and then dinner afterwards, whether it's seeing friends from college, right? And as a caregiver, it's always important to mediate the degree of that activity with their impairment. So if they're relatively impaired and they're really struggling to find the words to say and kind of track a conversation, throwing them into a banquet hall maybe isn't appropriate, right? But a one-on-one conversation, having family come over, having this long-term friend come over and just socialize a little bit. And it doesn't have to be in-depth conversations of, well, how are you? How's your mood? How are you feeling, right? It can literally just be, remember that one time in college when we did this? Right? And bring the joy and bring these really positive things so this person starts to feel warm and fuzzy when they're engaging with people, because then they really enjoy it.
So as the disease declines, we're now talking about Alzheimer's.
Okay.
What do you recommend that you do? You've said that maybe the significant cognitive testing just isn't going to produce any results. Is there any value in any doctor visits whatsoever at that point?
Absolutely. I think there is value in maybe tracking the decline, because at that point, if they're relatively declined on neuropsych and they're presenting what we call floor effects, they're going to be impaired on your cognitive screeners. Then you can track, at these repeat appointments, how they're scoring, and they may be dropping a couple points, right? And I think having those open conversations with a provider about, well, they're starting to decline a little bit, opens the door for what are next steps for care? What are next steps for assistance? Maybe I need to start talking about bringing in help in the home, or maybe I need to start talking about placement because I don't have the availability to be a full-time caregiver. So having those conversations with providers about the current stage and where they're at in their functioning helps kind of understand for a caregiver maybe what degree of assistance they may be needing, because it's really challenging to be a caregiver and carrying that burden on your own, and sometimes having a doctor say, well, this sounds really challenging. Where are you at with maybe bringing in some additional help can help kind of open your eyes and understanding that you might be at that place.
So you're saying that the doctor can really help you as a caregiver figure out your own care efforts and your own care health and things like that.
Absolutely. Yeah. And I definitely recommend, doctors are really swamped and really taxed, and they can really encourage, this person is declining and they're struggling. It's not uncommon for doctors' offices and things to have a social worker or to have a care manager, right? Embedded within the system, or Alzheimer's Association or Alzheimer's Orange County also has case managers and care managers. Talking to a social worker about these things when the doctor says, there is a bit of a decline and it does sound like you're struggling more, they can absolutely help you kind of get pointed in the right direction of additional services that you may need.
Well, this has been great. Is there any one message, though, that you'd like to give to caregivers? You see a lot of patients, but you also see the caregivers that are with them.
Yeah.
What message would you like to leave with caregivers?
I think that caregivers forget to care for themselves, and I am astonished and amazed, and I'm always floored by the amount of dedication and love that a caregiver has for their loved one. They are so dedicated to the point that they forget that they have their own needs, and understandable. But it's, that same thought when you're on an airplane and the oxygen masks come down. You always put your own mask on first so that you can help the people around you. And with caregiving, because it's such a slow process of it starts small and then now you're doing more and more and more and more for your loved one, you didn't realize that the oxygen mask came down. And you didn't realize that you've kind of forgotten to care for yourself in a lot of ways. And I am also always devastated when something bad happens to a caregiver because they have forgotten to care for themselves. And what happens is they may leave their loved one without a caregiver. And that's devastating. It does happen. And I think that that is the thing that, as a provider, one of the things that breaks my heart the most, because I'm like, no, now what? Like, this feels so all-encompassing because they loved so hard that they forgot to love themselves. And so I think as a caregiver, it's so important, don't forget to love yourself. It is not selfish. And I think that's the message. It's not selfish to find respite care.
Excellent.
Perfect way to end.
Yeah. Would you like to
Perfect
add
way to
anything?
end. No, I just think this is just, you're full of really, really good information, and a lot of people out there are going to appreciate it.
Thank you.
Yeah, I'd just like to say it's interesting to hear from people who have the kind of passion for what you're doing. And atta girl, way to go. You found something that you love to do and that you're doing incredibly well.
Thank you. Yeah, it's a great job. For all the people out there who are considering, what do I do with my life? Neuropsychology is fun.
Well, we'll close on that. Thank you so much. Spotlight on Care is produced by the University of California, Irvine Institute on Memory Impairments and Neurological Disorders, UCI MIND. Interviews focus on personal caregiving journeys and may not represent the views of UCI MIND. Individuals concerned about cognitive disorders, prevention, or treatment should seek expert diagnosis and care. Please subscribe to the Spotlight on Care podcast wherever you listen. For more information, visit mind.uci.edu.